Thank you very much. I'm delighted to be here by Zoom to present a historical perspective of G protein coupled receptors and take you through the initial discovery and then more recent areas of investigation of receptors both in vitro systems and in vivo systems. So let me share my screen. All good? Terrific. Well, thank you very much. Again, I'm delighted to be here. So let me start with a case. A 32-year-old male I saw in clinic last year with 8 weeks of progressive shortness of breath. He had COVID in August of 2021, and after that developed severe shortness of breath with exertion and profound exertional fatigue. Had P&D and 3-pillow orthopnea. When I saw him in the clinic, he was quite ill. His blood pressure was 146/90. His heart rate was 127. His respiratory rate was 27. Bibasilar crackles. His JVP was elevated. He had low volume carotid upstrokes. His apex was diffuse and displaced. He had a palpable S3 in addition to an audible S3 and a apical systolic murmur. His extremities were cool and he had 2+ bilateral pedal edema. Here's an echocardiogram. And what you could see is a dilated and markedly dysfunctional left ventricle with severe systolic heart failure. So he was admitted from clinic. He initiated initiation of therapy, received IV diuresis, and sequentially started on guideline-directed medical therapy with Carvedilol, and the pivotal trials that demonstrated their usefulness are shown on this slide. He was then started on Entresto at a low dose, spironolactone, and dapagliflozin. After 6 days, he was discharged with a life vest. So with that, and we'll come back to him, this person later on in the talk, but let's begin now with our journey of GPCR. So what is a GPCR? It's a G protein coupled receptor, and the basic unit of a GPCR is a receptor, a 7 transmembrane receptor that is one of the largest classes of receptors known. We often in cardiology deal with the adrenergic receptors, beta adrenergic and alpha adrenergic, the dopaminergic receptors, but a large, very, very large family of sensory and olfactory and taste receptors make up this GPCR class. They couple to a G protein. There are many alpha and beta gamma subunits, and different receptors will couple to different classes of G proteins, which then, upon agonist activation of the receptor, will enhance coupling of the G protein and lead to effector molecule activation and signaling. And for the beta-adrenergic receptor, that would be adenylyl cyclase. For the angiotensin receptor, that would be phospholipases, and can activate channels as potassium channels and calcium channels. So to remind us, beta-adrenergic receptors, carvedilol and metoprolol, spelled incorrectly here, are beta-adrenergic receptor antagonists, and angiotensin receptor antagonists such as valsartan or losartan. We now know that the receptor in its inactive state has a fairly close conformation, and then with ligand binding or agonist binding, several things happen. There is a conformational change in the receptor such that the transmembrane loops rotate outward, especially transmembrane loop 6 and loop 5. It creates a cavity on the undersurface of the receptor where G proteins, the G alpha subunit, can engage and stabilize an active conformation of the receptor. And it breaks what's called an ionic lock at transmembrane 3. So we know at an atomic level some of these very fundamental changes that occur when an agonist ligand binds the receptor. But that was not the case for many, many, many years. Indeed, from an historical perspective, the concept of a receptor was first proposed by Langley and Ehrlich in the 1900s, where they proposed that a receptor may be a link for the endogenous regulatory molecules in drugs. And in fact, Langley was the individual that named the substance a receptive substance, which are acted upon by chemical bodies. Raymond Ahlquist in 1948 postulated the existence of two types of adrenergic receptors, alpha and beta. But just to demonstrate that the concept that a receptor, an adrenergic receptor or any receptor, was a physical entity was in fact in great debate. In the 1955 edition of the Pharmacological Basis of Therapeutics, the main book of pharmacology, the quote is, "The term receptor is still widely employed, but it must be realized that the receptor may not be a morphologically distinct structure." So even in 1955, even though many people postulated, there was no definitive evidence that a protein or that the receptor was a physical entity. In 1960, Earl Sutherland identified and discovered cyclase, the effector molecule that generates cyclic AMP, the effector enzyme that generates cyclic AMP as a response to catecholamine. Here, with a single dose of epinephrine, one notices an increase in contractile force preceded by an increase of cyclic AMP. And in fact, in his Nobel lecture, Sutherland did not even propose a receptor. He postulated that a hormone would somehow cross the membrane, activate cyclase to result in a physiological response. In the early 1970s, Rodbell and Gilman identified G proteins, and they demonstrated that the transducer, the G protein bound to a guanine nucleotide, can be activated to stimulate the effector molecule cyclase. Receptors are postulated, but not integral to the activation of G protein. Here, the alpha subunit of G protein bound to GDP is exchanged for GTP, where it then may dissociate with a putative receptor not known to activate the hormone or to activate the effector cyclase C and stimulate cyclic AMP. So even Rodbell and Gilman were not convinced that a receptor as a physical entity existed. So it was in the mid to late 1970s where Bob Lefkowitz, when he came to Duke, developed a method and a quest to identify whether adrenergic receptors existed as physical entities. And the way he went about to do this was to identify whether there could be high affinity binding to, in this case, alpranolol, which an antagonist, to some sort of crude preparation of erythrocytes that contain receptors. And what he could demonstrate is that binding of this tritiated ligand is saturable. And that was very important because that suggests that it binds to an entity and as a physical entity. If it was non-specific binding, then you would just have a linear increase in the tritiated amount in your sample. It wouldn't be saturable. So this was the first evidence that there was high affinity specific binding of a ligand to some sort of structure, or at least entity, in the membranes of these frog erythrocytes, crude preparation of frog erythrocytes. He went on to then demonstrate using ligand binding that, in fact, that you could identify high affinity states and low affinity states of the receptor. And what that implies is that there are some conditions where the receptor likes the ligand better than it likes the ligand in other states. In other words, a high affinity state versus a low affinity state. And this led to what's known as the ternary complex model. And the ternary complex model is a model that demonstrates cooperativity between the G protein and the receptor. When the receptor is not engaged with G protein or ligand, it's in a very low affinity state. When the ligand interacts with the receptor, it results in a higher affinity state, which then engages the G protein. And now there's cooperativity, as shown as by this arrow going both ways, to further enhance the affinity for the ligand, a high affinity state, the so-called ligand receptor G protein complex, ternary complex. This was a major breakthrough, because what this suggests then is that not only can radioligand binding demonstrate receptors as a physical entity, you could use radioligand binding to not only know how much receptor is there, but also know the physical status of the receptor. Is it in a high affinity state coupled to G protein, or in a low affinity state? Back to our understanding of heart failure, it's important to note that the prevailing wisdom in the 70s was that one should not use beta blockers. It's something that, as you think of our therapy of heart failure today, it's just so counterintuitive. So beta blockers propranolol was developed by Sir James Black in the 1960s. In fact, he developed it for his father, who had coronary disease and angina, and he felt that if he could block the effects of adrenaline with propranolol, then there would be less symptoms of angina. And it was considered that beta blockers were contraindicated in heart failure. The rationale was that patients in heart failure are critically dependent on sympathetic activity, and that in heart failure, if there's when cardiac output is not sufficient to meet the demands of the body, so the definition of heart failure, reducing output further with a beta blocker is illogical. And this was adapted from an editorial from Pritchard in the British Journal of Pharmacology. And this was in 1978. And this was in hot debate in the 70s, and largely because of very pioneering work from Laxton and Hjalmarsson in Sweden, where they published a report of 7 patients who received beta blockers and were in severe heart failure. So these 7 individuals were given beta blockers, either alpranolol or Practilol. They had severe congestive cardiomyopathy, and they had resting tachycardia. And what they showed is that there was an improvement in their clinical condition shortly after the administration of drugs. And in fact, I think they should be credited with the idea of the so-called neurohormonal hypothesis. They postulate that increased catecholamine activity may be an important factor for the development of this disease. Michael Bristow, in the early 80s, took the radioligand binding technique that Bob Lefkowitz developed and demonstrated our current understanding of what happens to beta receptors in failing heart. He demonstrated that beta receptors, there was almost a 50% decrease in receptor density. He also did cyclase assays and demonstrated almost a 50% decrease in cyclase and a reduction in catecholamine isoproterenol stimulated muscle contraction. In other words, desensitization. Evidence for the neurohormonal hypothesis really was pioneered by Jay Cohn when he published a survival curves for patients with heart failure depending on their baseline entry level of plasma norepinephrine. And one could see that the higher level of norepinephrine, serum norepinephrine, the worse survival, indicating that, as was predicted or postulated by the Swedes, that in fact, catecholamines may be detrimental to the remodeling, or at least to the cardiac function and survival in the long term. This concept of desensitization, though, that was demonstrated in clinical heart failure by Bristow, was also demonstrated early on by the Lefkowitz lab. What they demonstrated here is that if you administer isoproterenol and look at cyclase activity experimentally in cells, you could see a robust increase in cyclase activation and cyclic AMP generation. But if you pre-incubate with agonist for a half hour or so, and then come back and re-administer isoproterenol, there was marked loss of that increase. In other words, the receptors were blunted to the second dose of isoproterenol, a phenomenon called desensitization. And they were incredibly intrigued about this, which led to a decade and a half of work demonstrating the molecular basis for desensitization. First, they demonstrated that the receptor, shown here, is phosphorylated. And this was demonstrated by a mobility shift of the receptor. And this is a phosphoblot where you could measure the level of radioactive P32 incorporated to your protein. And if there's incorporation of P32 or phosphates, it retards the mobility. And one could see that as you pre-treat or stimulate with isoproterenol, there is phosphorylation after agonist stimulation. This led to the discovery of several entities. First, in the middle 80s, Brian Kobilka, working with the Merck group and a collaboration between Bob Lefkowitz and Kathy Schrader at Merck, using a DNA library, a cDNA library, were able to identify and clone for the first time the beta-adrenergic receptor, demonstrating its 7 transmembrane topology. Quickly thereafter, they identified the kinase that phosphorylates the receptor, as was shown earlier, and they named that kinase the beta-adrenergic receptor kinase. This is now, we call it G protein coupled receptor kinase, or GRK, and there's seven members of this GRK family. And subsequently, several years after that, they identified another scaffold or cofactor called beta-arrestin, which binds to the phosphorylated receptor and interdicts further signaling. So the mechanism of desensitization was completely worked out in the mid to late 80s. The identification of the receptor, the phosphorylation of the receptor by the G protein receptor kinase, the beta-adrenergic receptor kinase, BARC, and then the subsequent recruitment of beta-arrestin to the phosphorylated receptor, which sterically interdicts G protein coupling and leads to desensitization. It was in the early 1990s that Unger and Losey demonstrated in human heart failure that all three components are dysregulated in heart failure. And the three components are both beta-adrenergic receptors are abnormal in the sense that there's decrease in density of the beta-1. Beta-2 receptors are not markedly downregulated. Both receptors are heavily phosphorylated. There's an increase in the GRK bark, the kinase that phosphorylates the receptor, leading to the molecular mechanism for desensitization. In the mid-90s, I started collaborating with Bob Lefkowitz and Wally Koch and Carmelo Milano, and to investigate whether the identity of these molecular mechanisms in vitro or by static molecules can be demonstrated in vivo in the intact organism. And so what we did is we overexpressed the beta-adrenergic receptor kinase or an inhibitor of the beta-adrenergic receptor kinase in the hearts of mice using transgenic technology. At that time, it was not routine. And we could demonstrate that in response to isoproterenol, you could desensitize the heart if you overexpress the kinase, or you could, in fact, enhance contractility and responsiveness to isoproterenol if you give an inhibitor of the beta-adrenergic kinase. And this essentially sets up or at least confirms the observation in human heart that if the beta-adrenergic receptor kinase is upregulated, it's desensitizing the system. If you do something to either decrease or downregulate the beta-adrenergic receptor kinase, then you can enhance the adrenergic system. And in fact, we went on to demonstrate that in a heart failure model systems in the mouse, that if you block or inhibit the beta-adrenergic receptor kinase in a model of heart failure, this is an M-mode echocardiogram in a mouse that lacks a gene, a protein that's associated with the myofilament and is associated with an abnormal cardiac function, that if you prevent the increase and block the beta-adrenergic receptor kinase, you could actually reverse remodel the ventricle from a poor function to a almost normal function. So this brings some pharmacology lessons that we've learned. So basic pharmacology has it that as you increase drug concentration and you look at the biological response, you could see several patterns. If you have a full agonist, meaning that agonist stimulates the receptor to its maximal efficacy, one would see a response as you increase agonist to its maximal effect. And this, in a sense, is from the ternary complex, ligand shift and receptor shifting the equilibrium to high affinity active receptor engaging G protein. A partial agonist, something like Pindolol, for example, has a blunted effect, will still stimulate, but not to the same level as a full agonist. What was controversial is there such a thing as an inverse agonist? In other words, is it possible that you can develop a ligand, or is there a ligand that binds to the receptor but shifts the equilibrium to the inactive state? In other words, it would take the basal function, whatever minimal that is, and reduce it to almost zero. In other words, any one or two receptors that are spontaneously activated would be shifted to the inactive state. Well, we proved this in vivo by using one of the mice that Carmelo Milano made, where we overexpressed the beta-adrenergic receptor and found that if we administer specific ligands that shut the receptor down and shift this equilibrium, we could demonstrate this concept of inverse agonism. And in fact, now most ARBs do exactly that. Losartan, candesartan, telmisartan, when they bind to the receptor, they actually turn any receptor into an inactive form, a state, and consequently fails to signal. In the late 90s, early 2000, we recognized a very important phenomenon, and that is not only did beta-arrestin block signaling and therefore is a G protein inhibitor, activator, or G protein signaling inhibitor, but it also can scaffold a number of different molecules and lead to activation of signaling in its own right. In other words, beta-arrestin is recruited to phosphorylated receptors to blunt or to interdict G protein signaling, but simultaneously can also activate signaling in its own right. And indeed, the confluence or the portfolio of signaling that occurs with Arrestin and G protein, although there's some overlap, is in fact distinct. And so therefore, Arrestin is a signal transducer in its own right. So from the adrenergic receptor, what we learn, and now that's our current working hypothesis or paradigm, is that when it's engaged by ligand, an agonist, for example, it activates G protein, the ternary complex model, to activate second messengers and cyclic AMP for beta receptor and the response. So when you get up and run, one then notices an increase in heart rate. The reason for that is norepinephrine activates the beta receptor to stimulate cyclase, cyclic AMP in the heart, and there's an increase in sinus node activation and an increase in contractility. Very rapidly, GRKs, beta-arrestin, GRK, the BARC, the beta-adrenergic receptor kinase, or GRKs, phosphorylate the receptor, recruit beta-arrestin, and turn off that signaling through a mechanism of desensitization. At the same time, Arrestin results in its own independent signaling, and we've identified numerous pathways where this signaling can occur. One intriguing aspect was the ability of beta-arrestin to signal through the epidermal growth factor receptor. And what we identified was a mechanism by which beta-arrestin scaffolds a molecule called SARC to lead to over several molecules, activation of molecules, lead to the release of epidermal growth factor locally to local epidermal growth factor receptors to increase ERK MAP kinase. So this is called transactivation, and it's via the beta-adrenergic receptor, and it's typically seen with, say, norepinephrine. But what was intriguing was we tested the hypothesis, is it possible that other ligands, not agonists, could stimulate Arrestin signaling? And so we use this as an assay, and this is epidermal growth factor in green now, it's tagged with GFP. And when these GFP tagged epidermal growth factor receptors are unstimulated, they live on the membrane. But if you stimulate the receptor, they go inside endocytose into these small endocytic vesicles. If you give EGF, they go inside the cell. If you administer dopamine, the beta-1 adrenergic receptor agonist, they go inside the cell through a process of transactivation as identified. What we found, though, quite remarkably, was that some beta blockers also do this. In other words, Carvedilol and alprenolol, shown here, stimulate the receptor to recruit Arrestin and activate EGFR signaling. In other words, some beta blockers, although classically would say, well, they don't do anything. They just block the receptor and they block G protein. That's absolutely true. But some of them can stabilize a conformation that when Arrestin's recruited, they actually signal. And that's not true for propranolol, pindolol, atenolol, timolol, and metoprolol, many others. So we found that some of these beta blockers are quite unique. And in fact, to this day, we still study Carvedilol. This led to the hypothesis of what's called bias signaling. And so what's bias signaling? So bias signaling is that we know that the G protein, when it's activated, can signal. We know that beta-arrestin can signal in its own right. And when you give a balanced or endogenous agonist like norepinephrine, you could see both pathways, as I described. The G protein's activated, and Arrestin subsequently is activated. But what happens if you have an agonist where it stabilizes a conformation where only G proteins are signaling? Or for that matter, you have a ligand that stabilizes a different conformation that doesn't stimulate G proteins, but only stimulates beta-arrestin signaling. This, in a sense, is biasing the receptor to one signal transducer or another. So we call these biased ligands or biased agonists. You can have a G protein biased agonist or a Arrestin biased agonist. And in fact, Carvedilol is a weak Arrestin biased agonist. And so at the level of the receptor, biased ligands stabilize distinct active receptor conformation to engage distinct transducers. And what we've demonstrated now over a number of years in experimental studies, that the Arrestin signaling in the heart is often cardioprotective to ischemia reperfusion, to effects of cell survival effects, decreases apoptosis. It can decrease the level of hypertrophy, whereas sustained G protein signaling in the heart, part of the neurohormonal hypothesis, leads to detrimental effects. And we're engaged now in trying to identify ligands that enhance one of these pathways, either G protein or beta-arrestin signaling, depending on what clinical phenotype that is most interesting to try and treat. So let's recap. The G proteins were identified in the 1980s by Rodbell and Gilman. Adenylyl cyclase was identified by Earl, Sutherland. I didn't mention Krebs, Ed Krebs, who identified phosphorylation as the key effector or of second messengers, and translates and transduces, I guess, the cyclic AMP signal by phosphorylating cellular components to enhance the cell response. And then in the 80s and 90s, and to this day, Bob Lefkowitz and Brian Kobilka identified the machinery that the entities of the beta-adrenergic receptor as a physical entity, and how ligands activate and induce conformational changes of the receptor to activate and engage G proteins, and the desensitizing mechanisms, and indeed Arrestin as its own transducer. I want to close in the next 10 minutes with going back to the patient and also talk to you about current work that we're engaged in. So 3 months later, on medical therapy, not on maximal doses, but on maximal tolerated doses of the agents that I described, his functional capacity was markedly improved, less short of breath. He had no signs or symptoms of or signs of congestion. I was able to up titrate most of his medicines, and his EF was 35% on repeat echo. His LV size decreased somewhat, and I was able to discontinue the life vest. I want to make a point, though, about medical therapy. For some of us who've been on this journey for many decades, we remember the first ACE inhibitor trial, the consensus trial. I'm not sure if it was a first, but one of the first ones that was published in '87, comparing placebo to enalapril. So placebo was Digen-Lasix, and they were then randomized to enalapril, the consensus trial. I want to point out that in the group that had Digen-Lasix, the 1-year mortality was 60%. It was a dreadful disease. It still is, but in the 80s, it was a dreadful disease. I want to point out the current DAPA-HF trial that was published in 2019. These individuals had similar ejection fractions. They were all less than 35%, and many of them were as sick as the people that were enrolled in the trial 30 years earlier. The 1-year mortality, or in fact, is almost 5%, and 2 years, 10% on maximal medical therapy, and a remarkable evolution of our understanding of heart failure and treatment based on years and years of both experimental studies and investigation and clinical trials testing these hypotheses. I want to point out that this is without ICDs and CRT, which I shouldn't say without, but in addition to ICDs and CRT. But I want to make a point that there's a need for novel ligands. And the reason for that is this. There's a huge variability in the response to beta blocker. As you could see here in the clinical trials, some of the Carvedilol trials had marked response. Bucindolol had very little response. Nebivolol had a mild response. And in fact, if you look at patients, it's very difficult to get patients on maximally tolerated, maximal doses. And in fact, we know that if you look at landmark trials compared to registry trials, most patients are on a fraction or less than half or less than half of what the trial dose was used. And we also know that benefit is dose dependent. That if you're on the maximal doses used in the trials, you'll get the maximal benefit. But the problem is that many patients have unwanted or intolerable adverse effects. One approach is to target the receptor in a different way, and that's called allosteric modulation. So what's an allosteric modulator? Well, norepinephrine and angiotensin bind to what's called the orthosteric site. It's a binding pocket on this extracellular surface. They wiggle their way into this little pocket and they stabilize an active conformation of the receptor, shifting it from LR to LR star, as I described. An allosteric modulator binds to a site that's distinct from the orthosteric. It could be anywhere. One of the transmembrane units, one of the intracellular loops, one of the extracellular domains, a site that is distinct from the orthosteric ligand. And these allosteric modulators then become cooperative with the orthosteric. They could either enhance the activity of the orthosteric ligand, we call that a positive allosteric modulator, or they could blunt and decrease the cooperativity of the orthosteric ligand or the activity of the ligand, and by stabilizing an inactive conformation. And we call this a negative allosteric modulator. Well, why are these valuable? One is that there is huge diversity between receptors in the transmembrane domains. There's not that much diversity in amino acid diversity in the orthosteric ligand. That means the likelihood of identifying a molecule that is unique to one receptor subtype is much higher because of the diversity between beta receptors and alpha receptors and subtypes. Whereas trying to find beta receptor subtype specific ligands that target the same orthosteric site is actually not easy. And we don't have great ones. We have ones that are maybe, an order of magnitude different at best. They could modulate the affinity and efficacy of orthosteric ligands. In other words, a positive allosteric modulator can enhance the activity of an orthosteric ligand, so you could use a lower dose and perhaps less side effect. And as I mentioned, they have enhanced receptor subtypes. So in fact, we were involved and demonstrated that we could identify an allosteric ligand that does exactly that. So this compound 6 was identified in a small molecule DNA-encoded library screen by the Lefkowitz laboratory for the beta-2 adrenergic receptor. And what was used was a receptor, a purified receptor screening a large library. We wanted to test whether compound 6, this compound that was identified, actually shows cooperativity to beta receptors, specifically the beta-1 adrenergic receptor. And so what we did is we created beta-1 purified beta adrenergic receptors in lipid nanodiscs, so it mimics a natural environment with an HDL belt. And we looked at competition binding for isoproterenol. And what you could see is that in the closed circles is the control condition. And in the administration of compound 6, you could see a very, very little shift, almost imperceptible shift, leftward shift to higher affinity. So basically minimal. But we said, well, wait a second, let's try a bunch of ligands. And sure enough, what we could see is for carvedilol, it was much more active. In fact, it was almost a log shift different. So in other words, this compound is in binding to an allosteric site on the receptor and increasing the affinity for carvedilol. And what was even more surprising was it's only for carvedilol, not for any other beta blocker that we tested. And we tested a whole panel of them. In fact, you could see that for some of them, it actually inhibits the binding. But by and large, these curves are superimposable. So it's a unique effect of carvedilol. I won't go through all the study, but just to demonstrate the point that I was trying to make. Well, can compound 6 as a positive allosteric modulator for carvedilol enhance the good stuff, but block or at least diminish the untoward effects? So what we did is an in vivo study where we looked at the response to heart rate and contractility to isoproterenol. And in black are wild type, or they're all wild type hearts, but no treatment or vehicle. And you could see that as you give catecholamines, you get a marked increase in heart rate and a marked increase in contractility. Now, if you pre-treat with carvedilol at a low dose, in this case, blue, you could see that low dose carvedilol doesn't do much to heart rate or contractility, right? That's great. A high dose of carvedilol completely blocks the heart rate response and markedly blunts the contractility response. So that's what would be expected. What you would do if you had a heart failure patient is try to give a high dose of carvedilol to block the catecholamine response. But what I want to point out is the line in orange. In this case, we had co-administered carvedilol and compound 6, low dose of carvedilol and compound 6, the allosteric modulator. It had no effect on, it did not enhance the blocking activity of carvedilol. So in this case, if this was an individual being treated, that person would feel as if they had low-dose carvedilol. But what happened to its protective effect? So we did ischemia reperfusion in these animals, and we could demonstrate that compound 6 had no effect, that carvedilol had the low-dose carvedilol had a mild effect, but compound 6 plus low-dose carvedilol had a marked response. In fact, was equal to the high dose of carvedilol. So in essence, the administration of compound 6, an allosteric modulator, potentiated the low dose of carvedilol to be equivalent from the cardioprotective effect to a very, very high dose, indicating that perhaps one could maximize the beneficial effect, but decrease the untoward negative effects of the drug. And in fact, we are now currently engaged in a very, very large DNA-encoded library screen to identify specific allosteric modulators for the receptor engaged to G protein, receptor engaged to beta-arrestin, the receptor engaged with ligand but no transducer, and our appropriate controls. And we just finished the screen using a library that has over 1 billion compounds, unique compounds, and we identify a bunch that we're currently testing their pharmacology and in vivo relevance. So let me conclude now with a few minutes left for questions. Allosteric modulators are, we think, the future where you could have agents to increase signaling and enhance the cooperativity of ligand to both G protein and arrestin signaling, a negative allosteric modulator where it would blunt the norepinephrine response. I could see this, for example, in exertional angina, where you could give a low dose of beta blocker plus an allosteric modulator and blunt the heart rate response to exercise without the untoward effects of high dose of beta blockers. Or even more exciting, perhaps, would be a bias allosteric modulator, such as compound 6, but perhaps one that takes norepinephrine and makes it biased. So with that, I'll close and introduce my laboratory. These individuals all work tirelessly on this, both the in vivo and in vitro work. The compound 6 work was done by Jailu in the laboratory, and now continuing by Alyssa, and then individuals in the lab, particularly Lan Mao and Long Chen, who do the in vivo physiology. So with that, I'll stop sharing. And I see there are some questions.